Okay, so for the most part, once again, some of you guys in the audience are going to be like, well, I think she's got a pretty good smile. Why are we doing anything? Once again, what we do is we ask the patient, and we do have some numbers that we can identify. So, for example, we did identify that she's got 4 millimeters of gingival display whenever she smiles. The other thing that I didn't touch on is if you measure the central incisor, she measures at about 9 millimeters. Okay? Average central incisor length is about 11. So for those of you in the audience who have not done this before, just about every tooth, the numbers are close to 100%, can be lengthened to 11 millimeters without exposing the cemento enamel junction. Okay? Now that's not, obviously we're assuming that there's no tooth wear. So whenever we do this, and she's numb now, if I wanted to get her to 11 millimeters, which would be ideal, this is where we would be. So what you got to do is you sink your probe down in this area and make sure you find that CEJ, okay? And her CEJ is right at about the 2.5, 3 millimeter mark, which means that we do not want to lengthen beyond that point or she's going to be mad at us. Mm-hmm. So the rules of carpentry apply here. You measure twice and you cut once, all right? So the way we always do it, we measure 11 millimeters and we'll make a bleeding point with our probe. Bleeding points, you don't want to do this on a patient without being numb. But the neat thing about it is they don't scar or anything, so if you can always move your bleeding point. So what we're going to do, we're going to measure 11 millimeters at the midline. And the rules of aesthetic surgery is you go 1 millimeter to the distal of that, and then you just simply make a bleeding point. Okay? So when we started on number 8, you always start with the central incisors because if you can nail the central incisors, everything else is pretty easy from there. So you guys can see the bleeding point here. We're going to do the exact same thing. We're going to measure 11 millimeters. We start off at the midline. You go 1 millimeter to the lateral of it. And you make a bleeding point. Now remember, the centrals and the canines are supposed to be about the same length roughly. The next most common mistake that I see is that they'll strictly measure the teeth and put a bleeding point there. Now keep in mind, it's not necessarily the length of the teeth that need to be the same, it's the gingival margins. Okay? So with the centrals and the canine here being roughly the same, we can actually make a bleeding point there and it'll be pretty close. But if you look over here on her other canine, where we've got some attrition or perhaps a fracture there, you don't want to go 11 millimeters from the incisal edge. That wouldn't make any sense at all. So what you got to do is just come straight across here. And make a bleeding point. Now keep in mind, these are just bleeding points. You hadn't cut anything yet. And on canines, just because of how we view them from the front of the mouth, you can actually make your bleeding point directly underneath the center of the tooth. Once again, you got to check where the CEJ is so you don't expose it unintentionally, and it's right there. So at this point, when you're in practice, you don't have the benefit of a screen. So when you're practice, what you'll then do is you'll sit the patient up and look at your bleeding points and make sure that they're where you like them. So I'm going to actually have to look at the screen here and see where we're at. And I think we're in pretty good shape. And then with our laterals, you do those next, and they go, it's very easy. You just go 1 millimeter apical, or incisal, to the other bleeding points. Very simple. And they do follow the 1 millimeter to the distal of center rule. All right. So there we've got all of our bleeding points. We know exactly where we want to lengthen it. Next thing we do, measure twice, cut once. So we want to make sure that we find those CEJs one more time so we don't expose anything unnecessarily. And there's our front 6. Now, remember, she's got a little bit of vertical maxillary excess, so she's a little bit gummy slightly in the front as well as in the back. So we're actually going to go back to the premolars on her just slightly. Let's go about 10 millimeters long on these. Now the question is, hey, when you get to start cutting here, do you use a laser or do you use a blade? What are the benefit, pros and cons of all this? For me, we prefer using blades. The reason we do that is because blades are more accurate because they don't burn. We're just strictly incising the excess tissue. And it's also faster. Lasers are basically designed to either cut tissues that have a lot of water in them or inflammation. Now, attached keratinized tissue doesn't have a whole lot of water content comparatively, and her tissue really isn't inflamed. So the laser would take literally for 5 times longer to cut than a blade would. Now, when you get to the premolars, remember one of my rules that we can't break is the rule of not creating a mucogingival defect. So if you look over here on the premolars, you're going to identify the mucogingival line right here. So if we lengthen it there, we got to make sure that we leave Dana with at least 2 millimeters of keratinized tissue and 1 millimeter of attached tissue, and we can clearly do that right now. Now in the front, on the incisors, obviously it's not an issue at all. So with that, check the CEJs one last time. You guys can probably tell I'm really worried about CEJs. It's no fun trying to reverse the procedure. It's kind of like unringing a bell. Can't do it. Not without additional surgery. And nobody likes buying restorations for patients. So the first thing you'll always do, once again, you'll always start off with the central incisors. A lot of people will start from the distal of the tooth and go to the mesial aspect of the tooth. I don't prefer to do it that way because the biggest thing for me is going to be trying to make the zeniths of the gingival margins where they're supposed to be. So I always start at the bleeding point, and then I always go mesial. And you basically just follow the cemento-enamel junction. Just like so. You'll remember from your tooth morphology reviews that the mesial line angle has more of a convex contour, whereas the distal line angle is usually more straight. And there you go. So there's your tooth number 8. And now all you got to do is tooth number 9 and make them similar. Now, with 15 blades, when you're cutting close to the enamel, they will tend to dull very rapidly. So you'll want to have plenty on hand. Usually they're good for about 2 teeth, and you got to switch them out. Sometimes people ask, well, what do you do if you slip? Well, unfortunately, the only answer to that is don't slip. So we got central incisors to the length that we want. We're at about, right on about 10.5 millimeters. Once again, you can do 11 safely. CEJs are way down here, so we're fine. We haven't exposed any CEJs. So now all we got to do is just, now that we've nailed the centrals, we just got to keep going and take that data to the other teeth. I like to do the lateral incisors next, and we'll just go all the way back. This part will start going fast after you do the centrals. You doing okay?
Yeah.
So you pretty much do your centrals and laterals in the same manner. We all know what those teeth are supposed to look like. Once you get the the centrals mastered, once again, it becomes dramatically more simple. Let's go back up to the front here, and this is what we got so far. So we've lengthened them about 2 millimeters, which is going to be enough of a difference to take it from 4 millimeters of excessive gingival display to 2, which is basically the international standard. So I think at this point we're pretty good. So we got to just move on and go do the centrals and then off to the premolars, and that will complete the first half of the procedure, which is just the basic gingivectomy style procedure. And back towards the center, if you will. So guys, let's take a look at this. We got our front 6. I think we're in pretty good shape. We've got some pretty decent symmetry. And now the easy part is just doing the bicuspids. Bicuspids, the reason I say they're easy is because they're pretty symmetrical teeth. They're not like centrals and lateral incisors, where they're one side needs to be more convex than the other. Premolars are perfectly symmetrical. Not only that, we're limited by both, at least on Dana, we're limited by where her CEJ is as well as where her buccogingival junction is. So we can't just give her the moon on this. But we can lengthen it, a couple millimeters safely. Now I know what some of you guys are thinking. You're like, when are we going to start taking away some bone? Well, we'll show you that here in a little bit because we got to talk about the biologic width. What you guys are seeing right now is just the easy part. As far as armamentarium goes, you guys will notice so far I haven't used anything but just a 15 blade. Some people like using 15Cs, which is a smaller blade. However, for me, I feel like you have more control over a 15 blade because it's got a broader and blunter tip. All right, guys. So far, back to the front again, Dana. We got our front 8, and we're lengthened up. We got some pretty good symmetry. Everything's lengthened up about at 2 millimeters. So I think we're at a really good point right now. There's not a, obviously there's always improvements, but I think we're looking good right now. Now the next thing that we talked about when we were doing the lecture portion of this is we talked about the biologic width. You can't invade the biologic width, or you have to be mindful of it. So what does that mean? So I gave you guys a few diagnoses to where we can help people like Dana with their gummy smiles. The first one on that screen said excessive gingival display or gingival overgrowth. And with gingival overgrowth, if this was true gingival overgrowth, we would be done with the procedure right now. We would just give her post-op instructions, and we'd